Okay, so last time we talked about the cross reaction, and the cross reaction was the reaction between different antigens on the surface and antibodies. So what's a transfusion reaction? Transfusion reaction is if you got blood transfusion for some reason, you're in the hospital and you needed some blood, you got blood transfusion, and you got something wrong. You're type A and you got a blood of type B. What type of antigen in type B? What type of antigen in type B? B. And what type of antibody in type A? B. So obviously there will be a cross reaction between the antigen that was introduced and the antibody that was there, and this will lead to agglutination and hemolysis. What's hemolysis? It means breaking down the RBCs. Antigen from one side and the antibodies in the plasma, and they will react together and they will break down the RBCs, so that will lead to hemolysis. That's if the two types are not compatible. This is how they actually do it in the lab. If you ever got a blood typing, this is exactly how they do it. They get just a drop and they put a drop like this, okay, and they add anti-A, anti-B, and anti-D. All right? If your blood is A+, do you expect reaction with anti-A or anti-B antibody? If you're type A. If you're type A, what type of antigen do you have? A. And I added anti-A and anti-B. Which one is going to react? Huh? You are type A. Think about it again. Forget about the plus now. You're type A. What kind of antigen you have on the surface of your blood vessels?
A.
A. So what type of antibody can react with this?
B.
B antibody react with A antigen? Why? A antibody react with A antigen. B antibody react with B antigen. And that's why if you're type A and you have type A antigen, you can't have type A antibody or you will kill yourself, right? Did you get the concept? The antigen is like the number on your house. How do you know your address? You look at the number, 23540 Harper Street, whatever, right? So there is an address that tells who you are. This is your antigen. So each cell, there is an address on it, which is the recognition site, which is the antigen, okay? So if you are type A, so you have the antigen type A, it's impossible to have type A antibody, but to react with your cells, killing all your cells. You can't have that. So if you have antigen type A, you cannot have antibody type A. You have to have type B. Are we following? So now I give you a drop of antibody that's called anti-A, and another drop of antibody that's type B. Which one will react with your antigen A? A. So I will see it on the slide looking like this. What is this? This is coagulation. They reacted with each other. Is it going to react with anti-B? No, because it doesn't have B antigen, right? And you're positive. You're positive. I give you anti-D. If you're positive, do you have the D antigen or not? Are you following? Did you study this? What do we mean when I say you're positive? What do you mean by that? I am B positive. What do you mean? B, okay, that's the antigen. What's positive mean? It's another antigen. You either, but there are no types. There is another antigen. The main antigen is A. You have antigen A. You have antigen B. If you have antigen A, I call you type A. If If you have antigen B, I'll call you type B. If you have both antigens, I'll call you type AB. If you have 0 antigen, I will call you O. So this is one antigen. You might have another antigen or maybe not. And there are no types. You either have it or you don't have it. If you have it, I call you positive. If you have the antigen D, the D antigen, if you have it, I'll call you positive. If you don't have it, I call you negative. That's it. Did you get it? So there are two components that give you the blood type. Are you A? Are you B? Are you AB? Are you O? This is one. You have to be one out of those four. The second part, are you positive or negative? How to tell? You either have the other antigen or you don't have it. You have it, you're positive. You don't have it, you're negative. So if you are A plus, do you have the antigen or not?
Yes.
If I give you the antibody against that antigen, is it going to react? Yeah, so this is how it looks like. They will come together, break down, and this is how it looks like. This is just, looks like this, isn't it? This is nothing happened. So how about type B? If I give you anti-A, is it going to react?
No.
No. Do you have antigen A?
No.
So it's not going to react. I give you anti-B, is it going to react?
Yes.
Yes, because anti-B will react with the antigen B, it will react, and you're positive. Anti-D, do you have the antigen RH antigen or not?
Yes.
If you are RH positive, what's positive? It's RH, the other antigen, right? Which is the D antigen. So you do have it, it's going to break down. How about AB? I gave you anti-A, react, anti-B, anti-D. So this will tell us if you reacted with both of them, I would say that you're type AB. How about O? This is O negative. Forget about negative, it's O. I gave you anti-A. Do you have antigen A? How many antigens do you have?
None.
0. So I gave you anti-A, doesn't react because you don't have antigen A. I gave you anti-B, it doesn't react. You don't have antigen B. I gave you anti-D, you don't react. You don't have the D because it's minus. If it is positive, is it going to react here only? Right? Are we following? Okay. So this is about the blood typing. So cross-matching is cross-matching test. You are in the hospital and we wanted to know what type of blood should we give you. We will do the cross-matching. A donor, your cousin, your brother is coming with you and he needs blood, we don't have blood, he's going to donate. Okay, let me cross-match your blood together first. I see if you match together or not. If you don't have the time, O will work with anybody, right? So if your friend or your cousin or something coming with you, you wanted to save your life, and are you type O? Yes, okay, we don't have to match. So O is a universal donor. So usually the cross-matching, they by the way, just for your information, they usually do it anyway. Because maybe you forgot or something, right? Practically speaking. Even if you told me you're type O, I'll still have to do it. What if you're wrong? You forgot or you didn't do it in a reputable lab or something, you never know. So just to avoid the possibility, cross-match is always done. The next type of cells is the white blood cells, also known as leukocytes. Does it have nucleus or not? White blood cells. Does the red blood cells have nucleus? What's the exception? What if you see nucleus in the red blood cells? What does it mean? We talked about this last time. What does it mean? We're not supposed to see nucleus in the RBCs. But during the development of RBCs, you start with hemocytoblast at the beginning, and then which have nucleus, and go from this to the next nucleus. Next have nucleus. Next have nucleus. Only it disappear when you make the actual mature RBCs. So the last step only. So you develop from this have a nucleus, have a nucleus, have a nucleus, have a nucleus, and this is the mature RBCs, the nucleus disappeared. So what does it mean when you have a nucleus? It means it's premature. You didn't have the time to make the full mature RBCs. And this is actually something that they do use. They use it. If I look at your blood and I see some RBCs with nuclei, I will tell you, you know what, you're having immature RBCs. Why is the bone marrow not taking the time to maturate the RBCs? Maybe you're pushing it too hard. Like what? Like if you're breaking down your heart, your blood all the time, fast enough, so you're not giving the time to the bone marrow to take the time to maturate the RBCs. Okay, and this is like exactly like this. If I'm making bread, for example, okay, I can make 30 per day. This is what I can produce. Give me my time, I'll give you the perfect bread. Okay? I'm taking my time. 30, that's what I can do. And now you're telling me, can you do 35? Well, it's too hard. No, you have to do it. Okay, it's not going to be perfect. Make it 40. That's too much. No, you have to do it. Okay, if that's the case, it's not going to be finished much. I will just do it like this and give it to you, right? Prematurely. So you didn't give me the time to put it like in the oven or something and have it well done. You're pushing me too hard. More. So since you're not giving me the time to take all the steps, I will give you prematurely. What's the premature form? It does have a nucleus. Did you get this? So what can push the bone marrow to work over time or to produce more? It can be either your blood cells are broken down too much, you're having a problem, and you have hemolysis for some reason. So the bone marrow is trying to replace, and it's overworking, so it will make mistakes. It will give you premature cells. Or you have a tumor in the bone marrow, and the tumor is taking the upper hand and pushing the bone marrow more. So you start to see these immature cells that does have a nucleus. Okay? How about the white blood cells? The white blood cells should have a nucleus. This is normal. Function, defense, basically. It's defense. So it defends you against what? Pathogens, against toxins, against waste products, and your own cells. It can protect you from your own cells if they are abnormal. Okay, so if you have one of your cells, your own cells, that's changing and becoming bad, like started to become cancerous or infected. Let's say just infected. If your cell is infected, do you have a need for it anymore? It's going to be broken down anyway. So your white blood cells will eat it and get rid of it. So not only that, your white blood cells will defend you against invading pathogens or toxins. No, it can even defend you against your abnormal cells. And this is actually good for the body, that anytime you have bad cells, you have to get rid of it. It's not good to keep bad cells in your body. Where are the white blood cells? Some of it will be in the blood. Some of it will be in the blood, but the vast majority is not actually circulating in the blood. It is in the connective tissue proper and in the lymphatic system. This is the major part. So what you actually see in your bloodstream is part of your white blood cells, not all of it. And you see from 6 to 9,000 per microliter, and you have to remember this number. 6 to 9,000, because this is the right number. If I got, of course I'm not going to take a sample from your lymphatics or something. Okay, if we wanted to take a sample and know if your white blood cells is okay or not, I'll get a blood sample and count. If it is 6,000 to 9,000, this is normal. What if it is 4? Is it normal or less or above or more? Less. What do you call less white blood cells? Leuko. What's less? Penia. Leukopenia. Penia means less. How about if it is 20,000. Is it too much? Yes. What do you call it? Leukocytosis. We will come to that. But cytosis means increased number of. Pinia, decreased number of. These are the abnormalities. So the white blood cells, part of it, 6,000 to 9,000 actually in the bloodstream, and they can leave. They have the amoeboid. What's the amoeboid? Like behaving like the amoeba. You know what's the amoeba? It's a pathogen that is very soft. It can be like this, and in 1 second it change and become like a cylinder. So it can work around. It's very flexible. So it can go through any pores and it can leave the bloodstream. So it has amoeboid movement. This is how it migrates out of the bloodstream. It will be attracted by chemical stimuli, and this is called positive chemotaxis. What do we mean by that? Here is what I mean. Do you remember the phages? What phages means? Like macrophages. Phage. Eat, yes. So macrophages are the big eaters, right? This is a type of the blood cells, white blood cells. And this is going around in the blood, okay? Going around, and when they see something wrong, okay, I stop here. There is a pathogen here. This is your macrophage, the big eaters. Moving around, okay, this is a pathogen. It's not supposed to be here. How did you know it's a pathogen? I recognize it from the antigen. Remember that every single cell or pathogens have a recognition on it, which is the antigen. Okay? So I see this antigen and I know now that this is a pathogen. And I see a lot of pathogens. I'm going to send a chemical messenger to tell the rest of the white blood cells that I started a fight here. I want you to come here, which is called chemotaxis. Chemo means chemical, taxis means attraction. Chemical attraction, meaning I send a chemical attractor, a chemical messenger, to go to the rest of the white blood cells to bring them over at the site of the fight, to help you fight. Okay, this is called chemotaxis, and this is one of the characteristics of, which is called the positive chemotaxis. What are the characteristics of the white blood cells? The phages. Phagocytes. Cytes means cells. Phago, eating. So these are the eaters, the eating cells, the cells that eat other cells, not necessarily cells, can eat toxins too. Okay, so it eats basically anything that you don't need, right? And this is men, M-E-N, the plural of man, men. Just to remember it, M-E-N. Those three are the eaters. Anything else is not. Okay, monocytes, eosinophils, and neutrophils. Now, if you look at the size of the monocytes, you will see them large, like this. If you look at the neutrophil, you will see them small. Monocyte, which is one of the phagocytic, will become macrophages. So monocyte, they will maturate and become macrophages, the large eaters. While the neutrophils and the eosinophils, but we focus more on the neutrophils, this will make the microphages. So depending on the size, what are the eaters? Any eaters is called phage. Is it macrophage or microphage? The monocyte is large, so this is the macrophage. The big eaters come from monocytes. The small eaters, the microphages, come from neutrophils, and don't forget this. Neutrophil will become your microphages. Monocytes will become your macrophages. Why? Because the neutrophils are small and the monocytes are large. Both of them are eaters. Yeah, but one is small and the other one is large. So here are the neutrophil. Compare this to this. Okay, so this is larger. Eosinophil is about the same size as neutrophil, but the monocytes are larger, like double or something. So these are the different types of white blood cells. What are the types of blood cells? You need to remember those. We talked about men. M-E-N. These are the ethers, right? Plus lymphocytes and basophils. So if I ask you, all of the following is white blood cells except. Example. Neutrophil, eosinophil, basophil, monocytes, and thrombocytes. Which one is wrong? What's a thrombocyte? Thrombo. What? It's responsible for clotting, but what do you call the cell? Thrombo. Platelets. Thrombo means platelets. So if I give you something like that, you should pick which one is not white blood cells. So we have men, LM. LB, sorry. Men, LB. Monocytes, eosinophil, neutrophil, plus lymphocytes and basophils. Neutrophils. The other name is polymorph nuclear leukocytes. Okay? PNLs. Polymorph nuclear. Why did you call it polymorph? What's poly and what's morph? Poly means many. What's morph? Shape. So why did you give it this? Everything I told you before, and I will keep on saying that. Everything in physiology makes sense. There is nothing that's random. You don't give random names. Why did you call it polymorph nuclear leukocyte? Because these are leukocytes. Their nucleus have many shapes. Okay? So if you look at the nucleus, you'll see it going like this, like this, like this. So it have different shapes. Okay? This is where the name came from. Everything makes sense. And this is the vast majority of the white blood cells. Most of the white blood cells are neutrophils. So what's the other name? PNLs. And this will develop and become what? Which eaters? Micro. Okay? We have lysosomal enzymes, and they are bactericides. What sites means? Side, not site. Like suicide. Side means kill. Suicide means kill yourself. Homicide means kill somebody else. Side, with a C, it means kill. So bactericides are the bacteria killers. So anytime you see neutrophils, you remember the following. The other name is PNLs. Number 2, to become macrophages. Number 3, bactericides, meaning these will kill the bacteria. Isn't all our white blood cells kill bacteria? No. They are specialized. This one is responsible specifically for bacteria. And you will see other ones that are responsible for virus, and others responsible for parasites. So there is some specialty. They share in certain parts, but let's go one by one. Neutrophil is for bacteria. It kills bacteria. So neutrophil, they move, and neutrophils is not the first one that encounter the pathogen. The neutrophils are scattered everywhere. Usually the first type that actually get in contact with the pathogen or the invader are the macrophages. So the macrophages go first. It's always going around. And when they need help, they call the neutrophils to come, and the neutrophils will come and kill the bacteria. But did the neutrophil is the first one to recognize that this is a bacteria? No. It will be cold later on. This is just to give you an example to understand it more. We always see the police cars going around everywhere, right? They are not specialized. Everywhere you go, you do a traffic violation, they stop you, right? You stop on the side of the way, they stop you. There is a fight, 2 people fighting, they will stop, right? So they are not specific in something else. They are just going around to catch anything that's not normal, anything that's happening, right? A suspicious car, stop it. A suspicious person, somebody stealing. So if there is a specialty here, should it has to be traffic? No. If this car finds two people fighting, they will stop or not, right? If somebody was hit, they will stop. Fight, they will stop. If somebody is jumping or breaking down into a car or a home or something, they will stop, right? So those are the first people who are always going around to catch something. But what always happens when they stop you? They call other police cars to come, right? Most of the time, unless it's something minor. But most of the time, you just give them a few minutes and you'll see 2 or 3 other cars coming, right? So the first car that always going around, this is their job, this is the macrophages. And the other ones that are coming to help are neutrophils. And others as well. But who told the neutrophils to come? Who told the other cars to come? Did they see you fighting? No. The first one that encounter you, they saw you, and they see you fighting, and then I have some people here fighting, I need some help. And they will come over. So somebody called them to come. Monocytes called them. How did you call them? By chemical messenger. You send a chemical messenger to the neutrophil, I want you to come here. I saw some bacteria here, some pathogens, and I started to control a little bit, but I will not be able to do it by myself. I need neutrophils to come. So neutrophils will come, and they will start to release some prostaglandins, leukotrienes, and some of these neutrophils will die in this fight. Some pathogens will die in this fight. They will exchange, they will fight, and the dead of this plus the tissues that will die, that will make the pus. So what's pus? Dead neutrophils, dead pathogen, dead tissues. So basically, the product of the fight. So after the fight is over, right, you see some broken cars, right? You see somebody maybe got a shot or something, and somebody's wounded, and so on. This is the outcome of the fight. So they call it a pus. Degranulation, some of the white blood cells that have granules, not all white blood cells have granules. Some of them does and some does not. These granules, if needed, it will be degranulated. So remove the granules, and you have diffencin that will attack the pathogen. Eosinophils. The other name for eosinophil is acidophil. And acidophil is basically, what's phil means? Phil. Like? Yes. Acidophil means it likes the acid. What do you mean like the acid? Meaning staining. This is something related to the lab. Okay, so if you put acidic stain, it will like the acidic stain and it will mix with it, or it will be stained with. There is another type that's called basophil. So obviously the same idea, right? What's a basophil? These are the white blood cells that likes the basic stains, and it will be stained by. So this is from the chemical point of view or from the laboratory point of view. The eosinophils are few, 2 to 4% only. Most important thing to remember about this is this. Parasites. What did we say about the neutrophils? What type of pathogen? Huh? Bacteria. And this? You know the difference between bacteria and parasites, right? Parasites, something like worms or something like that. So this is eosinophil. The other thing about eosinophil is allergy. So if I want you to remember two words about eosinophil, you should remember parasites and allergy. Okay? And by the way, when I say something like that, I'm actually giving you a clue for the questions. This is what you're looking for. If you see a question, a lot of things, and I'm asking you what type of cell. If you see allergy or parasite, choose eosinophil. If you see bacteria, choose neutrophil. Okay? So, most important thing to remember about neutrophils, bacteria, plus macrophages. What are the most important two things to remember about eosinophil? Parasite and allergy. Those two words, you cannot forget them. If you forgot something else, it's less important. But when I say something like this, do not forget it. This is the core. You have to remember this. Eosinophil, parasite, and allergy. How about the basophil? Basophil is only 1%. They accumulate in damaged area. And the most important thing to remember about the basophil is the two H's. Histamine and heparin. Histamine. I'm saying two words about each one of those. Okay? The most important two words. Basophil, the two H's. Histamine and heparin. Why are you doing that? Why the what's the function of the basophils? The basophils are important in inflammation. Inflammation. It's not really to fight. It's not like neutrophils and eosinophils and macrophage and other things. No, no, no. This is more for inflammation. So if you have an inflammation, what do you notice in your? Of course, all of us at any time we got some inflammation, right? What do you notice in the inflammation? Red, swelling, pain, warm, right? It will be warmer, right? So why is it swelling and why is it warm? Histamine. Histamine dilates your blood vessels, bringing more blood. Your inflamed area will start to swell, right? And start to get more blood, which carry heat. So that's the rationale. This is the reason why your inflammation is usually warm. It's warmer plus swelling. And there is a reason for that. Why did you dilate the blood vessels? I dilated the blood vessels to bring more blood to help healing the inflammation. All right? How about heparin? Why did you secrete heparin? Because not only did I want to dilate the blood vessels to bring more blood, but I also wanted to avoid any blood clot that stopped the blood from coming to me, right? What's the aim of all of this? I need more help. So the basophils are helping bringing more blood. How? Dilate the blood vessels so more blood will come and prevent the clot, that if the clot happen, you know the clots, right? Clotting of the blood, it will block the blood from coming. So the goal of basophils is bringing help, bringing more blood. How? Histamine, vasodilation, heparin, blood clotting. Prevent blood clotting. Monocytes. These are the largest of all. I didn't say the major ones or the numbers. I'm not talking about numbers. I'm talking about size now. What is the vast majority? The major one? Numbers? Neutrophils. So monocytes are 2 to 8%. You don't have to remember all these names, but what I want you to remember is the vast majority are neutrophils. And the smaller amount is everything else. That's good enough. So this is large and it will become what? When they grow, they will change to become macrophages. And this is the first one that will encounter the pathogen. And it will send a chemical messenger to attract other types, specifically neutrophil. What do you call the chemical attraction of other neutrophils? Chemotaxis. So what the big eaters will do what? The big eaters will eat. Will eat what? Anything that you don't need. Anything. They will eat it and then break it down inside, basically. And they will send the chemical messenger, which is chemotaxis, to call for the immune system to come, and also fibroblast to come. What's a fibroblast? Fibro means fibers. You know the fibers, right? What's blast?
Breakdown.
Lysis means breakdown. What's blast? It's, I know it.
Build up.
No. Blast, you're close. Blast means immature cells or precursor of. So when I tell you fibroblast, when it become mature, what do you call it? Fibro what? What's the name of the mature cell? In Greek? Cyte. Fibrocyte. How about osteoblast? This is a mature form of bone cells. What it will become? Osteocytes. Yes. Chondroblast. Chondrocyte. Okay? This will be used everywhere in physiology. Anytime you see blast, at the end of anything, it means the immature form of. And all what you need to do is remove blast and put site. This will be the mature form of. Can you remember this rule? Important. Every time you see it, it will apply all the time. So fibroblast, osteoblast, chondroblast. Anytime you see blast, it's immature form. So now why you're calling the fibroblast? Because fibroblast will become fibrocyte and it will produce fibers. And the fibers will close the injured area so you can clean it and repair it. This is the rationale. Why did you call? I understand you're calling the other immune cells to help you in the fight, but why are you calling fibroblast? Because fibroblasts, when they come, they will become fibrocyte and they will produce fibers, and the fibers will help you to seal and repair the area. So it's helping you in two directions, helping you to fight, to get rid of the pathogen, and it's not only about the pathogen. Don't you have injury, right? So you repair the injury as well. Lymphocytes. This is another major part. And the lymphocytes are small, just a little bit larger than RBCs. They can leave the bloodstream, and most of them also are in connective tissue and lymphoid organ, just like the rest of the white blood cells, but this is lymphocytes more in the lymphatic organs. And this is a type of specific defense. Lymphocytes are responsible for specific defense. What is the in-specific or non-specific defense? How can you defend yourself against pathogens? In general, not specific, not something, you're not specialized in something. What generally speaking defend you in your body? Think about it. Mucus, yeah. Skin, isn't your skin protecting you? What happens if you don't have the skin, or if the skin is injured? Don't you see the pathogen entering in? Right? So isn't the skin protecting you? If I ask you, is it protecting you against parasites or against bacteria? Anything. Does it protect you against virus? Anything. Toxins, dust, anything. It's non-specific. Non-specific. So skin is non-specific. Fever. Fever. Fever is protective, right? Why do we get fever when we get sick? Because you're fighting. You know what's the good thing about fever? There is something good. The bacteria, not the bacteria, sorry, the pathogens in general, they work the best, the optimal is the normal body temperature. So if you get anything that wanted to invade your body, they are accustomed and they love 37 or 98.6. They love it. This is optimal. If you raise it, which is fever, they will start to become weaker and slow down and less active and more prone to be killed. Okay? So this is one of your protective mechanisms. Yes?
Also the body enzymes work better.
It is better for the body enzymes to work too. Okay? But regarding the pathogen, it will suppress it's not killing. Suppress the activity. It's less than optimal. It's not good for them. All right? So that's why you have fever. So if I ask you, is the fever specific for one type of bacteria or anything? Anything. Any pathogen that invades you does not like fever. Fever is bad for you and bad for them too. They love the normal body temperature. Okay? So this is called non-specific. Is it against certain type of bacteria? No, it's not. It's not specific. It's anything. It suppresses anything. Inflammation. Inflammation against what? Anything. Don't you get inflamed if you step on like a piece of glass or something? Yes. How about bacteria? Yes. Injury? Yes. Anything. And you get inflamed anyway, so it's non-specific. These are all called the non-specific mechanisms. Now, this is the specific mechanism. What do you mean? They are specialized. They kill something specifically. They have a specific function, not general defense. Does not defend you against everything. No, they are specialized. And the way I would like to explain this is more like, again, back to the police car. You have a police car, right? And it's going around, here's a fight, okay? I will call more police cars to come. I need some help. This is neutrophils, right? I'm calling neutrophils. How about this? While searching, I found some drugs. I don't know how to deal with the drugs. I know that I just make like a report or something and that's it. These cars, they're not specialized, right? They will not take care of everything. So guess what? They will stop you, make a report, and then just wait. I need to call the drug department in the police. Those who are specialized in this. Or you find something related to immigration, for example. They don't deal with it. They just, I want you to stop here, please. I will do the report and just wait. I need the immigration officials, right? So these are specialized. This is all their job. They know exactly how to deal with the situation of drugs. If you are the drug department, traffic violation, trafficking, that's what I meant, trafficking, not traffic, trafficking. They will call drugs, okay? So these are specialized. They can come only if you have something that they only can do, specialized. These are the lymphocytes. And we have 3 types of lymphocytes, T, B, and natural killer. And each one of those will do a specific function. Like, this is the drugs department of the police, this is the immigration, and this is human trafficking, for example, or anything, okay? Money laundering, whatever the specialty is. So each one of those will do a specific function. What's the specific function? T cells, they fight by themselves. So this is called cytotoxic. This is their specialty, cytotoxic. They fight by themselves. B cells are called humoral. They are responsible for humoral. What's humoral? Humoral means they produce antibodies. Okay, so here's the difference. Let's say we are a group of police officers and we have different ways of interfering. I want you to stay here and hold your gun, and if you see somebody's trying to shoot me, shoot him. Don't get in contact with him, not direct contact. Just stay away and shoot. While I am going to engage in a physical fight with him by myself. I am cytotoxic, T, and he is B, humoral, meaning it goes like this. I'm not going to touch you. I'm going to send you some antibodies to kill you. Okay? So this fight by itself as a cell, cytotoxic. This fight through antibodies, antibody mediated, or humoral, 2 names. Natural killers. What you should remember about the natural killers is, just remember it. They kill your natural cells if infected or cancerous. Can you remember this? Just to remember it. Natural killers. They kill your natural cells if they become infected or cancerous, right? So T cells, cell mediated, they fight by themselves. B cells, humoral, they fight through antibodies. Are we following so far? Any question? Did you get the difference? T cells, they fight by themselves, physically. They engage. B, they don't engage. They fight through antibodies, like gun. They stay away and they produce their antibodies. However, and this piece of information is important, B cells produce antibodies? No. They don't produce antibodies. They maturate first and become plasma cells, and then the plasma cells will secrete antibodies. Okay? So B cells fight through antibody. Yes, after maturating and become plasma cells. Are we following? Okay? So does the B cells fight through antibodies? Yes. But they have to maturate first to become plasma cells. Don't forget this. Natural killer, they will destroy your abnormal cells if they get cancerous or infected. If something happened, something like infection, inflammation, allergy, you can tell by counting these white blood cells, and these are the abnormalities that can occur. Take this as a rule. Cytosis at the end of any word high number of cells, whatever the cells are. It will not only apply here, it will apply everywhere else. So remember the rule and apply it for everything. Cytosis. If you see cytosis at the end of any word, it means increased number of cells. Which cells? Leukocytosis, thrombocytosis, erythrocytosis. See how it can apply for anything. So leukocytosis, increased number of cells. Which cells? White. Erythrocytosis, increased number of cells. Which one? Red. Thrombocytosis, increased number of cells. Which one? Platelets. Did you get this? The opposite is penia. The opposite of cytosis, penia. So leukopenia, thrombocytopenia, and so on. Anytime you see penia, means less number or weak. So this is leukopenia versus leukocytosis. Leukemia is a severe degree of leukocytosis. You don't call it leukocytosis actually, it's cancer. So is it going to be leukocytosis? Yes, but severe. So leukocytosis, let's say the white blood cells are from 7 to 11 or 7 to 10. This is a normal number. Okay? If it becomes 15, you call it cytosis, leukocytosis. How about 20? Cytosis. But how about 200,000? Do you call this cytosis? No. This is leukemia. This is an extreme level of cytosis. So if that's the case, you measure the white blood cells, you go to the doctor, blood sample, let me see the white blood cells, 15, 16, 20. Yeah, this is leukocytosis. Maybe you're having an infection or something, but it's extremely dangerous. If I count your white blood cells and it's 100,000, this is 10 times, 200,000, 500,000, too much. So a little bit of an increase, abnormal increase, leukocytosis, extreme increase is leukemia, which is cancer of the white blood cells. White blood cells are produced depending on which type are we talking about. Okay, so all blood cells in general, they start from hemocytoplast, and it go from one type to one type. You have the myeloid stem cells, and the myeloid stem cells are responsible for all of them except the lymphocyte. Okay, so you have myeloid stem cells, lymphoid stem cells. Lymphoid stem cells will make lymphocytes only. Anything else is coming from the myeloid stem cells. Okay, so the myeloid stem cells will give you everything else. Red blood cells, yes. Platelets, yes, they come from the same origin. Okay, white blood cells, yes. The only exception is that does not come from myeloid stem cell is lymphocytes. They come from their own origin, which is lymphoid stem cells. Okay? And remember, look at this. This is what I was talking about. Myeloid stem cells. Do you see a nucleus here? The purple? Or do you see this? Okay. So there is a nucleus here. Do you see a nucleus here? Yes. See a nucleus here? Yes. Do you see a nucleus here? No. So this is before it becomes fully mature. The only time when you lose the nucleus is when the red blood cells become mature. So I got a blood sample from you, and I started to see cells like these. There is a problem in the bone marrow. It's overworking. Okay? What does it mean? Hemolysis, breaking down your blood, or cancer, or a tumor of the bone marrow. So the common origin of all cells is come from hemocytoblast. Don't forget that. This is the mother of all of them. They all come from the same mother, hemocytoblast. And the hemocytoblast, which is this one here, hemocytoblast. Everything will come from this. So hemocytoblast will give you myeloid stem cells and lymphoid stem cells. But both of them are coming from? What is this? Hemocytoblast. Hemocytoblast. Don't forget this. This is the mother of all blood cells. Anytime. It will give you lymphoid stem cells that will give you lymphocytes, or myeloid stem cells that will give you everything else. Okay? So this is called the progenitor. The stem cells, the other name for stem cells is progenitor. Progenitor. Progeneration. This is going to generate everything else. So myeloid stem cells, everything except lymphocyte. Lymphoid stem cells will give you the lymphocytes. What's poiesis means? Production, yes. So lymphopoiesis, the production of lymphocytes. Where do we develop our white blood cells? In the bone marrow, except the monocytes. The monocytes will become macrophage away from the bone marrow, in the peripheral tissues. Okay? So you produced everything from the hemocytoblast. Where? In the bone marrow. Right? They will all become mature in the bone marrow, except monocytes will become mature macrophage in the periphery, not in the bone marrow. There are other tissues in the body that also important in lymphopoiesis, or it make lymphoid cells or lymphocytes, which is the lymphoid tissues like the thymus, spleen, lymph nodes, and so on. So it can be produced from other parts. Regulation of the blood cell population. What regulates the blood cells? There is something called colony stimulating factor. This is a factor that will stimulate the colony of something. So the M, colony stimulating factor, the factor that stimulates the colony monocytes, okay, and so on. We put granulocytes. So this is the CSF of granulocytes. What are the granulocytes? Ben. What was men? M-E-N. And what do you call them? The eaters. Men's are eaters. Ben are granulocytes. Men and Ben. 3 types of white blood cells. Or remember it your way. I'm just trying to help you with some abbreviations or something, but remember it the way you want. This is how I remember it from medical school back in 20-something years. Okay, I still remember that. Men and Ben. Okay, M-E-N, men, eaters. Ben, granulocytes. Just at the M, and instead of monocytes, you put basophils, and this will make the granulocytes. There is one that can stimulate both granulocyte and monocytes together, and this is called the GM. So G for granulocyte, M for monocytes. Multi-CSF for everything. That's colony stimulating factor for everything, all blood cells. This is just a summary. You can study it. It's wrapping up all what we talked about together, so it's useful. You can use it. The next type after we finish the white blood cells is platelets. And platelets in general function as, what's the function of platelets? Huh? Clotting. Blood clot. Blood clot. Okay? What's the other name? Thrombocytes. The platelet cells. Thrombo means platelets. Platelet cells. Thrombocytes. They used to call it this name. Clotting. The platelets lifetime or lifespan is 9 to 12 days. They circulate 9 to 12, and then the spleen will remove it. What was the lifespan of the red blood cells? Yes. 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 120 days, 4 months. So the lifespan is obviously very short. 9. There are shorter. There are things, but this is 9 to 12. So it worked for 9 to 12 days, and then the spleen will take it and break it down. But the good thing is we have a reserve. Most of the time, we're using only thirds. So in cases of emergency, example, you have a major accident and you're bleeding from everywhere, you can call your reserve, which is the 2/3. So normally, all of us here, everybody, we use only a third of the platelets that we have. The 2/3 will not be used. It's just for emergency. If you have an emergency, you can call up to the other 2/3. Here is another number that you need to remember: 150,000 to 500. So 150 to 500,000. This is per microliter. So the numbers that we need to remember: red blood cells, the average is 5 million, average. The white blood cells, 7 to 11, 711. Platelets, 150 to 500. Okay. Thrombocytopenia. What's penia? I think it goes without saying now. Low. And what's cytosis? Can you remember this way? Apply it for everything. It will work. Platelets are basically responsible for clotting, which is the temporary patching the damaged cells. Okay. So if you remember that this is clotting, this is good enough. But here is the actual job of the platelets. Let's say in your house you found like a water pipe or something that's broken and leaking. What's the first thing that comes to your mind? Do you put something to stop it, or do you call the plumber to fix it? Don't you stop it first? Or call the plumber and wait for 2-3 hours until your entire house is gone? You don't do that, right? Let me put something on it, stop it temporarily until the plumber comes and make the permanent fix, right? That seal, you can put something and like wrap it a little bit or something until the plumber comes. This temporary platelets. So the platelets will go, if you have an injury or something, the platelets will go to this injured or open part, and they just put themselves as a sealing. So if you do just like this, if you touch, it will bleed again. Did you ever have a bleeding and stop for some time and start to bleed again? Yes, because it stopped temporarily, just to have some platelets sealing it. Don't touch. If you touch it, the platelets are not permanent. They are just trying to stop the bleeding until the tissues regrow and the permanent fix will occur. So it is temporary seal. Okay, and then it will be removed, by the way. They just help you temporarily. Like you close the pipe, wrap something around it, here the plumber come, let me fix it for you, everything is fine. They take the seal away, throw it away, right? So the platelets is temporary. Thrombocytopoiesis, and this is the production of platelets in the bone marrow, as we mentioned before. Megakaryocytes start, the platelets start as a giant cell. It's different from anything else, from other cells. Cells are from cell to cell to cell to cell. They maturate only. This is not the case for platelets. The platelets start like a giant jumbo cell like this, and you break it down into pieces. Each piece is a cell. What is that huge? Megakaryocyte. What's mega and what's karyo? What's mega? Huge, large. What's karyo? Nucleus. So this is a cell that's huge and have a very big nucleus. And you break it down into smaller pieces. Okay? So megakaryocyte is stem cells or the giant cells that will make platelets. The production of the platelets is through thrombopoietin. What was the hormone that stimulated the production of the red blood cells? Yes. What is it? Somebody else? What's the hormone that stimulates the bone marrow to produce red blood cells? It comes from the kidney. What is it? Huh? Just one person? No? Erythropoietin? Erythro means erythropoietin making or forming. Yeah, so this is the hormone that comes from the kidney to stimulate the production of RBCs. Thrombopoietin, just similar to it, but for production of thrombo, which is the platelets, plus interleukin 6 and multi-CSF. Multi-CSF, you can put it anywhere, because this will stimulate the production of anything, all cells. Hemostasis, hemo means blood, stasis, stop. So hemostasis is stopping the bleeding. How do you stop the bleeding? Okay, it goes like this. Number 1, vasoconstriction. This blood vessel is injured. It's going to constrict. Why? So you don't lose a lot of blood. You're bleeding anyway, and you're losing blood. So I'm going to constrict to keep your blood from being lost. Number 2, platelets will come to temporarily seal it until the coagulation occurs to seal it and stay until the tissue repaired. So blood vessels will contract, and this will stay for like 30 minutes to occur from the endothelial cells. The hormone is endothelin, which is the hormone that make the endothelium come from the endothelial cells to cause vasoconstriction. And by doing so, the endothelium will become sticky. So when the platelets come to seal it temporarily, they will be stuck in this area. Otherwise, the platelets will come and see an injury and just leave it and go. Or it can stop just beside it, and it's not going to actually seal it. What make it seal it is the sticky surface of the endothelium of the injured area. Platelets will start to come 15 seconds after the injury, and it will make a temporary seal. So this is an injury. The endothelium, which is this, is going to break down first, and it will make the surface sticky. So platelets are moving, and they see an injury here, opened area. They will come to seal it, and they will be stuck. Some more platelets come, stuck, stick. What make it stick? It's the endothelial damage, which is endothelin. Adhesion, it will be stuck or become adherent to the surface, and they will aggregate to make the platelet plug. So again, the platelet plug is a temporary seal. Now the platelets will start to secrete some chemicals to continue the process of sealing or fixing. And this include thromboxane 2, serotonin, clotting factors, calcium. All of this will come, PDGF, all of these factors will come and attract other components to come and fix the injured vessel. Prostacyclin is another hormone that will be produced from the endothelial cells, and this is when you seal it already and you start to fix it. You don't want any more platelets to come. So prostacyclin will stop the aggregation after you start the process of healing. The third phase is the coagulation phase. Few seconds later, 30 seconds or more, like 30 seconds to a minute. This is where the actual coagulation occurs. So the red blood cells come and start to make a coagulant, and this is when you start to see like a red soft tissue on the injured part. This is the clot, and start 30 seconds after injury. So let me ask you this. Platelets start to aggregate and form a temporary seal within 15 seconds, right? And this is normal. If you had injury before, it will bleed for few seconds, 30 seconds, 20 seconds, 30 seconds, and then it will stop, right? Unless you touch or something, that's something else. But if everything goes normal, this is how it goes. How about this? You had an injury, minor, and instead of staying for 15 seconds, it stayed for 3 minutes, 5 minutes. Is that normal? Of course not. So if that's the case, you have coagulation problem. You have a problem with the platelets and everything else, okay? And we will talk about this later on. But for now, just remember that it takes about 15 seconds for the platelets to close, to temporarily seal, 30 seconds for the coagulation to coagulate and even enforce the seal. If it didn't stop within this time, there should be something abnormal. It's called prolonged bleeding, and we will talk about this later. So blood clotting, which is coagulation, it needs fibers, and it goes like this. Here is a blood vessel, okay? Here is an injury, happened to the blood vessels, right? The blood vessel will constrict first, right? So less blood will come, okay? That's one. Number two, platelets, the endothelium or the parts around this will start to make this surface sticky. So platelets coming through and going around, they will find this and they will start to seal temporarily, right? And start to aggregate. So now we don't have bleeding anymore. It stopped temporarily, okay? Few seconds later, you need some fibers to keep them in place. These fibers are called fibrin. Fibrin. And the fibrin will come from fibrinogen. Do you remember what was fibrinogen? One of the fibrinogen, globulin, albumin. What are these? Plasma proteins. So this is one of the plasma proteins. We have a lot of it in the blood, but in the form of fibrinogen. You can't have it in the form of fibrin, because fibrin will make clots everywhere in your blood. So it's always in the inactive phase. Fibrinogen does not do anything. Just plasma protein moving around, it doesn't do anything. Only when you activate it to become fibrin, it will become fibers that will seal itself with the platelets, and this is how the coagulation process starts. So fibrin network that will cover the platelet plugs, trapping rest of the blood cells, so sealing the area. What help in this process is coagulating factors, which is called procoagulant. Pro means with or before. And this includes proteins and ions that will attract calcium, for example. Do you hear about some people having hypocalcemia? They don't have enough calcium and they bleed more. Do you hear about this? You bleed for 2 minutes. Why? You don't have enough calcium. What calcium have to do with this? The calcium is procoagulant. It helps you to do this process. It's one of the ions that help you to do this. And this is why, if you don't have enough calcium, you bleed more. Or not more, it's prolonged bleeding. So these are the factors: fibrinogen, prothrombin, tissue factor, calcium, okay, proaxilurine. A lot of factors, but the most important of those to remember is those. 1, 2, 3, 4. The first 4. Calcium is needed. Fibrinogen is needed. Prothrombin is needed. You have to have those. The rest, yeah, take a look at it. But these are the most important ones. Okay? And most of them, as you see, will come from the liver. Tissue factor will come from the tissues. Okay, the process of doing this coagulation is very complicated. Okay, it doesn't occur like this. Not just platelets and fibrin that seal the area. Yeah, this is what you see. This is the end step. But before that, how are the steps coming one after one after one. I'm not going to ask you to memorize everything, but know that we have two pathways. We have an extrinsic and intrinsic pathway. The extrinsic pathway is start with the blood vessel being injured, so start from outside, and it will go step after step after step after step. The steps that I want you to actually remember are prothrombin will become thrombin. Thrombin will activate fibrinogen, and it will become fibrin. And the fibrin is the one that will make the action. There are other steps here. Okay? Factor 12 to factor 12 active, 11 to 11 active, 9, 8, and so on. There are a lot of factors, but you have to remember this. Prothrombin become thrombin, which activate fibrinogen to fibrin, and the fibrin is the one that's do the clot. Okay? How to do that? There are different pathways, but remember the last step of all of them. So this is the pathway. There is another pathway that's called the intrinsic, and this is called the common pathway. So the common pathway is what you have to remember. Okay? Intrinsic come from the enzymes inside. So extrinsic, why did you call it extrinsic? Because it's not coming from the blood itself. It's coming from outside. It starts by a signal from blood vessels. Extrinsic signal. Extrinsic pathway. Intrinsic signal will cause intrinsic pathway, which is enzymes within the blood. And the common pathway when they both meet. So, are you following this part? This is intrinsic. And this is extrinsic. There are other things, we don't have to go through all the details. There are a lot of factors, 12 factors that will go one after one after one. Same thing here. But at the end, there's a common pathway. Both of them have to go through this anyway. Prothrombin to thrombin, fibrinogen to fibrin. You have to remember this. The enzyme that helps this is called prothrombinase. There are 12 factors that we're not going to talk about in this part right here. I'm talking about this. Prothrombin to thrombin through prothrombinase, and then fibrinogen to fibrin, which is the common pathway. Okay? Now bleeding time. Usually by adding up vasoconstriction and then platelet plug and then the coagulation cascade, that usually should take a minute to 4 minutes. How about more than that? 10 minutes. This is prolonged bleeding time. There is a problem. Which part? Any part of what we talked about. But it's not normal that to be more than that. So now the question comes, why we don't have this happening by itself? What inhibit that? Anticoagulants. Why it's not happening all the time? We have anticoagulants like antithrombin 3. We have heparin, protein C, prostacyclin. These factors will prevent the clotting from happening by itself automatically. It does not. Otherwise, we will all have coagulation happening all the time, and it will block the circulation to the heart and brain, and we will die. Okay? So it doesn't happen. What prevented any one of those? Calcium, iron, and vitamin K, this is the opposite. They are used for to help the blood clot. Okay? So, and this is where we hear about this person doesn't have enough calcium in his body and he bleeds for 10 minutes, for example. Or, if you heard about this, here is somebody, okay, just give me a minute. This is a person who got severe pneumonia, for example, and he goes to the hospital. They try to treat him with antibiotics, just the capsules, didn't work out. It's severe. So hospitalized, send him to the hospital. And they started to give him a gram, which is too much. Usually the normal is 500, half. They started to give him a gram or 2 grams of antibiotics. For 15 days, he's severely ill. And they started to do that. What they fear the most when that happened? When you give him 2 grams 2 times a day, huge amount of antibiotics. What is the problem that they fear the most? The problem is, this is not only going to kill the bad bacteria that's causing pneumonia, it will kill your own normal flora. You have good bacteria inside your large intestine that makes vitamin K. Vitamin K. So if that's the case, automatically, in the hospital, anybody who's antibiotic will give him vitamin K automatically. Why? Because we are going to kill his own good bacteria that make vitamin K, right? Clot retraction, 30 to 60 minutes. Fibrinolysin is how to fibrilize. Okay, look at this, and I will go back to this next time again. What I want to tell you about this? Why I put this all together? Matching. If you did the matching wrong, I don't know what to say. Okay. I'm giving you the concept instead of asking you to. This was not part of the slide, by the way. I grabbed it from everywhere in the whole chapter, and I put them all together. So when you see this, it doesn't mean these are the questions. I'm using this. So if you see part of this in the matching, blame yourself if you got it wrong. I'm already telling you.